Christmas shopping, Christmas gatherings, and New Year's gatherings. But of course, the government will attribute this to their, evening curfew and lockdowns and things like that. But I think it's probably more to do with getting away from gatherings, and it's not that it's not at all to do with their measures, but I think they probably give it a little more credit than it's due.
Okay. My first question for you is, where are we in terms of our numbers? Where were we when it was particularly bad, when it was at the peak? Where are we today?
Yeah, we were brushing up towards 3,000 cases a day, and with the fear of going to 4,000 cases a day in Quebec. And we're down to somewhere in the realm of 1,500 cases a day. The positivity rate is varying between 4.5 and 5.5 across Quebec. Different areas of Montreal.
What does that mean? Again, if a person is a layman, what is the positivity of 4.5? What does that mean?
It just is the percentage of positivity of all tests done on that day. So that's actually an important marker, because that takes into account whether or not there's a lot of tests on one day, or whether or not it's a weekend and there's less tests in that day.
So out of 100 people, 4.5% are testing positive.
Correct. So for every 100 tested, you would have 4 to 5 cases.
Is that good?
That's lower than it's been in a while. I know today, I think the positivity rate was 5.8, but it goes up and down. We did get, quite, in certain areas of Montreal, we were above 10. So across Quebec, being down, 5-ish is good right now. Another interesting number is the RT. So at the beginning of the pandemic, everybody was talking about R0. R0 is the public health epidemiologic number, called the basic reproductive number, or how many individual cases, how many extra cases each individual case is estimated to produce. So at first, the R0 was thought to be 5. And once you put in measures, that value is supposed to drop. It was between 1 and 2 for a very long time, between the months of October and December. And starting, sort of the second week of January, we found that the RT has dropped below 1. It's down in the 0.8s right now. So that's good, because if it's below 1, that means for every case, there's less than another case being produced, which means that the rate of reproduction is slowing and declining.
So if we were to take the simple numbers that at the peak, previously we were at nearly 3,000 cases a day, and now we are at half that. That sounds like cause for optimism. Would you agree? If the cases in a very short period of time have now nearly halved, how are we to analyze that?
I would say that it means that we should get back to the basics, which are social distancing, appropriate social distancing, abiding by public health rules, which means right now, reduce personal contacts, no gatherings, hand washing, face covering, and proper ventilation in wherever you're together with other people if you're in a work environment. So these are the 4 principles that from day one have guided appropriate mitigation measures.
Okay. Something that I know so many people want to talk about and ask is the vaccine. So there's a lot to cover here. Let's first begin with who has already been vaccinated and who is next.
So the vaccination rollout has differed between different provinces because healthcare is a provincial jurisdiction. In Quebec, the schedule of who gets vaccines started with members of long-term care facilities, the public long-term care facilities, known as CHSLDs. And everyone who wanted a vaccine has received a vaccine at that first step. The next stage was healthcare workers. That includes all professionals, nurses, the peripheral professionals like physios, occupational therapists, et cetera, housekeeping staff, administrative staff, pharmacists, et cetera, that work in the public healthcare system. So it's ongoing, trying to get everybody who wants a vaccine to be vaccinated. The target is to get 75% or more in each category vaccinated. So the government feels they've attained that in the CHSL days. I could tell you that there's been some issues with certain categories of healthcare workers where there's an unusual degree of vaccine hesitancy, where uptake has been only 30 to 50% in some sectors. And that's multifactorial as well. And it brings us, it's a good segue into, you know, where we're at with vaccine supply and where we're at with a vaccine schedule.
Okay.
So the vaccine schedule.
Who's next?
Okay, the next group of people are supposed to be people in sort of, there's different terms they use in the French language, but really it's long-term care, but private or assisted living for the elderly. And this
So
is where
it's not going to the general population
not
just
yet,
yet.
not yet, no. And this is sort of where we're stalling a little bit. It's because of supply and also because of rollout and how you get this into these places. How do you get the people into vaccine clinics? So this is a bit of a logistical challenge. So we're kind of stalled there, but also we have to have vaccines available to actually give them.
Does Quebec have vaccines available at the moment, to the best of your knowledge?
To the best of my knowledge, what I saw was that we've used up 85 to 90% of the available stock, which means that there should be 10% in freezers somewhere. But that could be anywhere in the province, right? So I know
Right.
that you know, I'm associated with the CIUS Centre Ouest Montreal, and I'm not sure what they have left, but I'm sure it's not a huge amount because they've really been going as in an organized way, maybe not as efficiently as Israel, but they've been really trying to get rid of whatever they have. And you know, so whatever's in the freezer is being used up. If there's leftovers at another site, people are being called to come and take the leftover doses.
Now, I'm sure you've been reading, as I have, and as many viewers have, the sense that the major processing plant for Pfizer in Brussels was simply unable to keep up with the massive demand, and that they are shutting down for a 2-week period for renovation so that they can expand the European plant, which is where Canada has been receiving their supply from. And it will be, I guess, pulling the tablecloth from both ends. For the next 2 weeks, there will not be a supply, Pfizer has announced. However, in 2 weeks from now, there will be an enormous largening of the supply because of how they're able to increase the quantities that they are producing. They have made a commitment, and this the Prime Minister has repeated, that they will meet their targets of 4 million units to Canada by March.
Sounds good.
Is there
Let's
anything
see.
more that you can say from a professional perspective on that?
Not from a professional perspective, except that whoever's negotiating this should learn to negotiate better.
Why do you
because
say that?
because the supply and how it's being curtailed is disproportionate. So it's not that everybody across the board is losing 75% of their vaccine deliveries. Certain countries are losing 50% of their deliveries. Certain countries are losing, 25% of their deliveries. Canada is losing 100% in 1 week, and I think 75% in another week.
Why is that?
Only the people at Pfizer and the government of Canada can answer that question. I have my sort of thoughts about it, bordering on conspiracy theory, so I don't know if I should go into it. But I don't know if it's a coincidence that Canada, who has publicly declared that they're willing to mess with Pfizer's vaccine schedule, is going to now suffer a vaccine shortage because they've admitted to not minding to delay their vaccine administration. They
This
threatened
is
to do it. Pfizer threatened to do that, and they've actually done it under the guise of having a refit for their plant in Europe.
this is a very painful subject, and it really is troubling concerning, infuriating. At what point, now I know we've spoken about this privately, but I'd like you, for everybody who is listening or watching this watching the recording later, how can a government take it upon themselves to administer the second dose outside of the recommended 21 or 28 days for Moderna, when the testing that they have been able to bring this to a safety standard was only shown to be effective under those controlled conditions? So how can scientists say this is when it works, and then government officials determine that we're not going to administer it the way you have proven the science to be effective? How can that be?
I don't know.
I'm asking this question with as little emotion
Yeah,
as I can because I want to
yeah,
remain professional.
yeah,
I'm furious, and
yeah.
I'm sure I speak for so many people. How can, and I believe England is the other country besides Quebec and Great Britain, the rest of the world has been following the protocols. How could it be that the politicians can change the rules?
So the answer is actually there's a bit of history that goes into it, and then there's a bit of understanding how we approve medications in Canada and Quebec. So the first part of the answer has to do with vaccine schedules in general in Quebec. So vaccine schedules in Quebec have been altered, deviated from recommendations on a regular basis for years. And people may not know this, but if you even check in Ontario and you compare it to the rest of Canada and you compare it to what the CDC recommends, for instance, and then you compare it to what manufacturers recommend, you will generally find that Quebec's recommendations are somewhat off compared to those. And you could see that with respect to Prevnar, which is an anti-pneumococcal vaccine. You definitely see it with Gardasil, which is what's given in the public, publicly in the schools in grade 4 to everybody, all the young kids. They're not getting standard Gardasil vaccination. They're getting something that Quebec has concocted. So, it's and they actually have stated publicly that they feel that they can alter this schedule based on their success or their stated success of previous manipulation of vaccine schedules. They feel that their assessments of these things have been good in the past, and they're basing their manipulation of the schedule on these past presumed successes.
As
So
a
that's the
medical doctor, as somebody who works in the infectious diseases department, heads up the infectious walk-in clinic, what is your professional opinion on such a stance?
So let me tell you what my opinion is, but let me tell you that there's no consensus in the ID division. And the reason for that is the actual situation that's going on right now. So my opinion on this is I'm more of a purist, and I believe that I don't want to give someone a medication that I have no evidence for its effects. I want to be able to tell people everything I know about this medication and answer them with certainty. And I, I expect to be able to back that up with some type of science. So what happened with this vaccine, especially the Pfizer vaccine, is that the group that approves vaccines in Quebec, who reports back to the specialized group known as INES, which advises the government, looked at the statistical study of the vaccine efficacy, and they looked at the rate of the vaccine efficacy after 14 days after the first shot only. So you have to understand that when you do a statistical analysis, you start the analysis by choosing the number of people to put into that analysis to give it appropriate statistical power. They powered these studies with the bare minimum to have events post a second shot. So I'm not in favor of doing an analysis on a subgroup prior to the endpoint that they were powering the study for. So that's where you hear the number 90%, because they feel that when they do this sort of rehash and reassessment and look at the numbers before the second shot is given, that there is a vaccine efficacy of 90% for those who receive the first dose after the 14-day mark. The problem with this is that it ignores some of the basic science that's found in the phase 1 and 2 studies that look at the rate and extent of immunoglobulin production after receiving a first shot. It's not substantial. The second shot is what gives the boosting that really puts the level of antibodies to a much, much higher level, which may be what's needed to give overall protective for a prolonged period of time. So overall protection for a long period of time. So that's my reading of this, is that the second shot is actually required to boost the immune system, to give it an appropriate degree of immunity, and to give it longevity.
So let me ask you a simple question. Please God, in a few weeks from now, it sounds like at least 2 weeks, the private healthcare sector of old age homes and whatever the language we're going to be using for that, the sector within society will have received the vaccine. It will then go down to the 80 plus cohort.
Correct.
If I am an 80-year-old with an opportunity to receive a first dose, yet no end in sight as to when the second dose will be administered, but what has been confirmed is that it will not be within the 21 days or the 28-day period, should I, as a post-80-year-old, be taking the first dose of the vaccine, in your opinion?
Yeah. So if we look at some other recommendations, Health Canada has on January 11th, I got my vaccination, and on January 12th, Health Canada reformed their recommendation, looking back at these studies. So they looked at who got the vaccine and what types of delay amongst all vaccine candidates and people who got placebo, what was the longest time that was tolerated for their studies. And the longest duration was 42 days. So that's 6 weeks. So Health Canada and NACI, which is the organization, that's the Vaccine Advisory Committee that advises Health Canada, that advises the government. So that's the federal version of that. Felt that you can delay this with data behind it up to 42 days.
Okay.
That's still not even close to what Quebec is going to be doing, because Quebec has stated that they will likely delay this closer to 90 days. And their explanation for why they feel they can do this is because they've done it before, which is not really true, because no one's ever manipulated mRNA vaccines ever. So it's a bit of a weird thing.
I'm guessing the next question, I believe you probably don't have an answer to, because there's probably no data for it. Has there been any indication that if you delay the second dose to 90 days, is it effective? And I'm assuming you're going to turn around and tell me nobody has even done a trial for that.
Nobody has done a trial for that. There is no trial for that.
So we have no way empirically of knowing if the second dose will be of use, because it will be 3 months later after, as a minimum, 3 months later after the initial first dose.
Yeah, we won't even know it from Israel, which has a very advanced vaccination program, because to the best of my knowledge, they will have vaccinated everybody within a month of their first shot. So that we will have no data about a 90-day delay from their experience.
Mm-hmm.
And I don't think that any jurisdiction besides Quebec has opted for that. They've announced in their schedule that those who were vaccinated initially around December 14th should expect to be vaccinated again in March with a second shot. That would be about 90 days.
Wow.
That's assuming we have a supply that's, and they've claimed that they're going to be monitoring this, but I could tell you that I have no idea how they're doing that.
Wow. Okay, thank you. Changing subjects dramatically, let's assume, I know this doesn't apply to everybody, let's assume I have property in Florida. The governor of Florida has made an announcement that anybody who is paying taxes to the state of Florida is eligible for the vaccine. Should I be getting on a plane to fly to Florida in order to take the first, perhaps even the second dose?
Okay, so there's many parts to this answer. The first issue is you're going to Florida, and you're entering a whole different universe when you go to Florida with respect to COVID, because it also depends where you're going and how you're going to be living. So I tell anybody who's even questioned me about traveling, which I discourage in general, I tell them that, look, like, even if you're familiar with where you're going, living outside of your regular environment right now means that there's going to be an elevated degree of risk of some kind, because you may not understand what it's like going to the shopping centers for the first time, or getting to the groceries for the first time, where trouble spots might be, what types of behavior you might encounter. That's number one. Number two, if you have any other kind of healthcare concern and you're going to travel abroad, especially to the United States right now, if there's a concern that you may need any type of healthcare assistance or emergency assistance, you have to be prepared to not be able to receive it in a timely fashion. So, taking those two things into account, it becomes a risk assessment for yourself and a risk tolerance. If you have the capacity to get the vaccine and get it the way you want in Florida, and you think that you're willing to deal with those types of risks that I've described, then I have no reason to suggest that you don't go, except for my ultimate recommendation, which is not to travel. But everything is a personal risk benefit calculation right now. Remember that at this point, Canada may shut the borders to all passengers that are not, all types of travel that doesn't involve cargo. And that before,
Should they? Let me ask you a follow-up question. Should non-essential travel be banned right now? We are 2.5 weeks before, I'm speaking on behalf of the Jewish schools, 2.5 weeks before spring break. I know that the public schools have a slightly different timetable, but let's say between 2 to 3 weeks. Should families be going to a kosher, all-inclusive Cancun vacation right now? Should they be going to a kosher Jamaica holiday right now? Should non-essential travel be banned?
you said Jamaica. Now I'm gonna have issues. But um, anyways, I would say that they should have shut the borders in September, because if you can, one of the things about this pandemic, one of the bottom lines is you can't have everything. If you want to have schools open, which Quebec government is determined to have, then you have to expect that there's going to be an interchange between the rate in the community and the schools. So there's going to be an increase in the community no matter what, if the schools remain open. If you have the borders open to travel, now the land borders have been fairly shut. The air traffic has been a free for all. So if someone really wanted to go abroad, they could. There's no problem. They can come back up until recently without any kind of restriction, basically, except for a 14-day quarantine. That's nonsense, right? This should have been stopped. At the latest, it should have been stopped going back into school in September. But under the illusion of having closed borders, according to the federal government, we know that people can travel, and people did travel over the Christmas and New Year's time. And to my knowledge, people are still coming back from Florida.
Yes.
Now, if you come back from Florida or anywhere else, you're supposed to come back with a negative COVID test first. And we know also that some of these people are coming back with falsified COVID test certificates.
Wow.
So
Wow. That I didn't know. That's crazy.
yeah, and that's the other part of the COVID outbreak, is that truthfulness is lacking, and is one of, like, the truth is one of the downfalls of this pandemic. When people start looking for loopholes and trying to bend the rules, then that's when things get out of control. And it's been like that from day one.
Let
Whether
me
it's
ask you
trying to
a
have yeah.
Let me ask you another follow-up question. Should schools be closed during this 4-week curfew shutdown?
To me, it doesn't make sense to tell people they can't leave their houses at 8, but to keep schools open. I think if you're going to do it, you do it. You don't keep florists open and tell people they're supposed to be at home at 8 o'clock. It doesn't make sense. I don't know why a florist is considered an essential business, but whatever. The government decides on these things, but another theme of the pandemic, especially in Quebec, is half measures don't work. So if you're going to do it, you do it. And you know what? I think people would have been very happy to go all the way for a defined period of time, watch the numbers come down to less than 1,000 cases per day, and then slowly come out of it. And when I say slowly, I mean really reopen, ultra slow, with high schools opening much later than elementary schools, and businesses opening on very slow pace selectively. Having manufacturing and construction and florists open and then saying it's a lockdown, it's not a real lockdown. I could tell you there's more traffic on the street, on the highways going to work now than I had during the summer. So it's very unusual.
Let me ask you the impossible question, but as human beings who have been 10 months into this, we all want to know the answer that we intuitively realize nobody has, which is, given the timetable of how the rollout is coming along, yes, with now a 2-week dip, what is your estimation for seeing the community in the 80 plus bracket and the 70 plus bracket and even the 60 plus bracket having been receiving the dose of a first dosage and life going back to normal? When are we going to come out of where we are today?
Yeah, I don't think we can expect for life to go back to normal even after a single or second dose of vaccine for many months. So when will people above the age of 60 be receiving the vaccine? It really depends on how serious Quebec is about doing this, like a military style, like Israel is doing it.
Mm-hmm.
So they have to really rethink what it means to have an emergency vaccine campaign. This is not a standard vaccine campaign. This should be thought of as a military emergency style campaign. And in fact, I don't understand why the Canadian government isn't stepping in and saying that we are going to let the military do this. And, we're going to turn stadium and we're going to turn arenas into gigantic vaccine clinics. We're going to put the freezers in these places, and we're going to do like 1,000 vaccines every half day in each of these places until we're done. Because this is what needs to be done. It's not a matter now of like sitting down and filling out a form for 10 minutes and then having a chit chat with the nurse at the table, and table number 3 and 4, there's no one there because like it's not the right zip code, so no one's sitting there. Every chair should be filled, every arm should be being poked.
Mm-hmm.
Every time there's someone in that chair, the second it's finished, they should be getting out of that chair and someone should be sitting down and another needle be going into someone else's arm. And this should be going nonstop until there's no vaccines left in the freezer. And I don't think we're going to see that.
Thank you. I'm so happy for your candid response. Let me ask you another final question from me. There are many people who are watching us this evening. Once again, if you are on social media, we have maxed out our Zoom capacity. And if you know people that would be interested in watching, please refer them to my Facebook page. This is being recorded as well, and the recording will be sent out to the community later. I'm here speaking with Dr. Marty Teltscher, Director of the Infectious Disease Walk-in Clinic at the Jewish General Hospital. My last question for you, Dr. Marty, and then we're going to turn it over to the Q&A. If you're on Zoom, the Q&A box is available. And if you're on social media, you can write in the message bar. We have been understanding the variants and the mutations coming out of the UK, coming out of Brazil, and there was one other, I'm forgetting the third. South Africa. What do we know currently in terms of how effective the Pfizer, the Moderna Pfizer the Moderna vaccine is against the mutation? And as a follow-up, is this something which in the world of cell biology is just a inbuilt natural part of the reality, and we are to expect mutation after mutation, just like the common cold is ultimately a mutation after a mutation?
So you basically answered your own question, because coronavirus is one of the agents of the common cold. So the seasonal coronaviruses that exist with us are around, and they've become endemic, and we get the sniffles and we have runny noses from them, basically because they're able to mutate in such a way that they evade our immune systems and persist in the community and have become part of our existence.
Mhm.
There are other coronaviruses, such as the first SARS, which has disappeared, such as MERS, which kind of comes and goes, and hides in animal reservoirs. And now we're stuck with SARS-CoV-2. So SARS-CoV-2, like other RNA viruses, has various genetic machineries that are built into its coding. And it's one of the first things that gets coded when it comes into a host cell. And these proteins or enzymes are known to make errors, and RNA viruses are known to have built-in replication errors, and it's a natural event. So if you take another RNA virus, where this is a classic problem, which is HIV, we know that the replicase has a certain error rate, and it's because of that error rate that certain viruses are able to shift into types of mutations that evade certain types of antiretrovirals. And we know that there's certain classic mutations that can occur by exposing viruses to certain medications. So a patient could take medication A and develop known mutation B, and that medication becomes useless. And we know that that happens because we follow the patient and we switch to different medications. So in the case of these viruses, we know that there's a series of mutations, some of which are in the S protein, which is the spike protein, which is the target of the vaccine. And it's thought that because of these mutations, it's creating a variant that might be more transmissible, meaning that there may be a lower infective dose.
Mhm.
That might be due to various aspects, whether it's binding to our cell receptor more tightly, or whether it has other characteristics that it's inherited or developed because of these mutations. But initially, it was thought that they're not necessarily more virulent, meaning that they don't necessarily cause more disease. That was the initial aspect of this. Then there were some studies that came out from Pfizer and Moderna for these two, and Pfizer and Moderna said that the British variant, the vaccine should still be fine. So that's
Okay.
the B117.
Okay.
Then for the South African version of this, I think it's the B13511, something like that. Pfizer said that they're still looking into it. Moderna said that there is activity against that variant, but they may need to give a bigger dose. So that makes you wonder whether one dose would be enough of a Moderna vaccine.
Wow.
Right? Because they're saying that they have to give a reinforced booster potentially. So we're going to see what happens with that. That's the South African variant. So we're not 100% sure what it means with respect to how much disease it can cause. Initially, it was concerning that there was a higher rate in children.
Mhm.
Up until now, we've always felt that children have been grossly spared, except for unfortunate rare cases of some inflammatory type diseases. But there's an increased percentage of children that had become infected. But then afterwards, when reviewing things a few weeks into this new variant outbreaks, they felt that it wasn't that there was a higher percentage of kids, there was just more kids overall because there was more of everyone.
Right.
So the same percentage of children, just more of everyone getting infected by these variants. I know recently Anthony Fauci said that he feels that perhaps there is increased virulence. There's been some concern that some of these new variants may be worse for pregnant women.
I
So
saw that as well. Yes.
so we're still looking into all of this.
Allow me to now go to the question and answers which have been put forward to us. If you are just joining us. I am here speaking with Dr. Marty Teltscher, head of the infectious disease walk-in clinic at the Jewish General, who's answering our questions and answering your questions too. We have a shorter amount of time, so if you could, not just a yes or no, but if you could limit your answers, how soon after the second dose of the vaccine are you no longer capable of spreading the virus?
Okay, so here's that's, yes, no, I can't. It's okay. On a yes or no answer. Okay, so the short answer to this is even in the vaccine studies, it was shown, and the way they do vaccine efficacy studies is there's a placebo group, meaning they get an injection of salt water,
Mm-hmm.
and there's the trial vaccine. And in the trial vaccine group, there were still cases of severe COVID. Okay, and that's why it's not a 100% efficacy. Okay, in the global first shot analysis that's released by Pfizer, the vaccine efficacy according to Pfizer is 54%. That means that in the group that got placebo, for every 2 cases of severe COVID, there was 1 case of severe COVID in the vaccinated group.
Wow. So
If you're
even
looking,
after you are vaccinated, you are very much capable of continuing to spread the disease.
you can. There is still theory that it may not be what's called sterilizing immunity. So sterilizing immunity implies that the vaccine will either stop infection or, if infected, stop transmission.
Right.
And there's no evidence to claim that that is 100% true. So there's still a chance that you may be able to get infected, have a very mild version, or be asymptomatic, yet pass it on to someone else.
This brings us directly onto the next question. If a person had COVID-19 but never had any serious issues, can they A, get it again, and B, when they are feeling better, can they transmit it to somebody else?
Okay, so I'll take the second part first. Once you're recovered, generally a mild case in the community, we are saying that after 10 days, if you have no symptoms and you have a positive PCR, then 10 days after the PCR, we're saying that the chance of being infectious to someone else is close to nil.
Okay.
The first part is whether you can get reinfected. Overwhelmingly, we think that most people cannot get reinfected for at least a few months. So minimally something like 3 months, even if it's a mild case. If you're immunocompetent, meaning you have no problems with your immune system, we're thinking that you probably have at least 3 months, and some people suggest that maybe more, because there's parts of our immune system that we can't measure appropriately, such as cellular immunity, which may give you an added protection if you re-encounter it. That being said, we know that there has been documentation of reinfection. Many of these cases have altered immune systems because of hematologic malignancy, medications, whatever. And there's also a variation. So some people who have been reinfected have had a mild version, and some people have had a severe version. But these are rare events.
Okay, thank you. Another question, why are the doctors and nurses not protesting publicly with the support of the public for the delay in the vaccine?
So
I know that puts you on the spot politically, so you don't have to answer that. I know that
I'm not afraid of the politicians. At this point, they're already playing with my health. What else can they play with other than my money, I guess?
Right.
But people are afraid of repercussions. They are afraid. You have to understand now that since Barrette put laws in to reorganize how the healthcare system works in Quebec, the Minister of Health can fire anybody in any position in the healthcare system, from a sumanist down to a janitor.
Wow.
It's all encompassing, absolute power over the healthcare system. That being said, there are people who are not happy about this, but you have to also understand, like I said before, there's no consensus.
Right.
So there's two camps. The first camp is, let's put as many injections into as many arms as we can, because some protection is better than no protection.
Hmm.
Then there's the other camp, which is where I sit, which is appropriate protection is better than questionable protection. So I would rather give people vaccine properly and vaccinate 60 to 75% of the population than give everybody in the population one dose and cross my fingers.
And that is exactly the next question. Should I, as a 74-year-old, take the first dose if I cannot get the second shot for 90 days plus? And you just answered that.
Well, the ultimate answer really is, it's a matter of risk tolerance and where that individual sits. So I knew that I was not going to get my vaccine at 21 days. Okay, I didn't anticipate the government was going to be so bold to say that we know best, and we're going to give it at 90 days.
Right.
But I personally can't afford to not have any protection in the job that I do. So I have to take what I can get.
Right.
Which unfortunately, that's where I sit. And hopefully, when I get a booster shot, nothing weird happens to me, which I don't think will. But and hopefully, it actually does what it's supposed to do, which is reactivate the immune system and enhance it.
Right.
But there's no way to know what it might do.
Okay. Another questioner says, we are 3 people in our household. We each had a mild form of COVID, each having a different level of anxiety and fear as well. How anxious or fearful should we be now when we go out or engage with people as far as our distancing, etc.?
So you should behave as if you've never had COVID. That's the bottom line.
Okay.
Because having COVID is not an immune passport, meaning that you can't go around unmasked and say you've had COVID and you're fine. Trust me, that's not going to win you any friends. So just I would continue to observe all public health measures. It's a matter of being conformists in this case, because we want proper examples to be given to everyone, no exceptions at any time.
Next question, how do you assess the risk benefit of colchicine as a prophylactic or treatment, especially in older people?
Unfortunately, one of the other themes of COVID pandemic is the infodemic. So infodemic refers to a whole bunch of scientific papers coming out in the media, in preprint, prior to actually going through the channels of peer review, which is how most medical and scientific papers enter medical journals. So we've had a lot of red herrings, a lot of snake oil, a lot of static signal that we've had to sift through to try to find a true signal. There is no scientific paper right now for the Col Corona study that was based out of the Cardiac Institute in Montreal. We're waiting for the publication. Once the publication is out, we are eager to implement it if there isn't a signal that's thought to be appropriate. We have to also, an example of this is the hydroxychloroquine situation that occurred in the first wave. Now we have another similar situation with ivermectin. There was also a situation with the monoclonal antibodies that Trump received. All of these things made huge waves in the media, but when the science was reviewed, very, very underwhelming stuff.
Okay, thank you. Next question. Can you discuss the COVID long haul symptoms? People have continued to have many symptoms for many months and have developed new issues, myocarditis, etc. How will we be tracking these individuals to help prevent this from continuously happening? There are many post-COVID clinics set up all over Canada, none yet in Montreal.
We've been talking about this week, looking into what kind of clinics can be set up for this. The problem, post-COVID syndromes are real. There's no question about long hauler syndrome. This is actually probably the most frightening aspect of the disease with respect to what the future holds. Obviously, it's frightening for people to pass away from this disease. I don't want to minimize that, but fatalities from this disease are the extreme, rare event. Long hauler syndrome is not that rare. In some case series, 10 to 20% of all comers, meaning any degree of COVID,
Wow.
can end up with some form of a long hauler syndrome, which could be a combination of anything from myocarditis to pulmonary fibrosis to neurocognitive impairment, psychiatric illness, um, uh, kidney damage, liver damage, and a combination of all of these, temperature dysregulation, POTS syndrome, all of these weird types of autonomic disturbances that in the past, have been sort of sporadic, seem to cluster in some of people that have come through COVID. And then, of course, there's the inflammatory syndromes that we see in children and sometimes in adults. These are, who could follow these things? We're trying to figure out who would follow this. Once these things appear, it's not really an infectious disease anymore. So I was discussing today with a pulmonary specialist, and I was trying to explain to him that this is really in his domain. I told him I'm happy to help set up a framework for this, but it's really no longer an infectious disease. Once it gets to that point, the virus is gone. What's left is the leftover remnant immune damage and physiologic alteration. So, we're looking into it. We expect to see clinics being announced for this in the next month or two. I'm pretty sure that there's going to be some U2M affiliated clinic opening fairly shortly. That might be headed up by an ID researcher. I'm not sure what kind of patient care it's going to offer, or whether it's just going to be for sort of research-based stuff. But
Right.
we're looking into it.
Thank you. We're going to continue with some questions. I'm speaking with Dr. Marty Teltscher, head of the Infectious Diseases Walk-in Clinic at the Jewish. Next questioner asks, 2 of my daughters are in Israel and they want me to come. I have Israeli citizenship. They want me to come for a month and get the vaccine. Would you say the same about travel to Israel, as you mentioned earlier, to Florida?
No difference.
No difference. Okay, moving on. We have a number of questions. Now that the number of cases and hospitalizations is going down in Quebec, do you believe that the curfew will end as planned on February the 8th, or will it be extended?
We'll see what they do about that, because if they attribute the drop to the curfew, then they'll have a reason to extend it, which is why I say the curfew probably has some role in the decline, because I think in some respects it has caused people to take this seriously. But what I could tell you is that I don't know why they used the curfew in particular. I'm not sure if they were trying to target the 20 to 40-year-old age group
Right.
that might be gathering at night.
Right.
In the walk-in clinic, a good part of our business is STIs, and a good part of our business remains STIs, even though there is a curfew in place.
That's interesting.
So I don't know if the curfew is absolutely necessary, but it did give people a sort of sharp wake-up call as to, this is serious. So it could have changed people's behaviors just from the shock value.
Thank you. Next question. If a person does take the vaccine, the second dose, 90 days or later, can that second dose cause harm?
We don't know. So it shouldn't, in theory, and this is what the Quebec government is gambling on. There are other very unusual and rarer types of immunologic reactions, such as antibody-dependent enhancement, which actually causes tissue damage. But that's not usually seen with vaccines that we are using regularly. The problem is that we have not used mRNA vaccines regularly. So I can't, it's not the mRNA that's the problem. It's just the response that we don't know. I don't anticipate there being a problem, and I'm pretty sure that most people don't. I just hope that we don't have to take like 3 or 4 shots of this every 3 months, because we're not getting the proper immune boosting that we're supposed to see after 1 month.
That's you've just opened my eyes to a frightening new realization that I didn't think was there. There's always a new depth to where this rabbit hole can end, and I did not consider that this could be an every 3-month dosage, because we never built up enough immunity in the first.
Look, I hope Quebec will do their second shot. We don't have much of a choice for those of us staying here and not trying to get the vaccine in other channels. And I hope that they have someone ready to go to do a study immediately especially long-term care residents, where we know elderly people don't necessarily respond properly to these types of vaccines.
Another question, I'm now going over to social media, and a person is asking, what is your opinion about receiving the vaccine for somebody who currently has COVID?
If you currently have COVID, you should not take the vaccine. That's for sure.
What is the time frame for them to
Yeah.
then receive it?
So that's another thing that's not been well studied, or there's no real recommendation. Once you've had COVID, like I told you, you're probably immune for a good 2 to 3 months. I would say that I would probably wait a couple of months. There's no rush in general. Once you've had COVID, you should recover, make sure you're feeling well, get yourself back in form, and your antibodies should still be present up to 3 months. We know that. Unless you've had an ultra mild case, in which case you may not have had any residual antibodies, but nonetheless, your T cell immunity may be present. So the vaccine is not a priority, and I'm pretty sure that in both studies, people who have had COVID were excluded for the most part. So we're not even sure what the anticipated response is for a vaccine post-COVID.
Another question here from Facebook. Would rapid testing at airports be of any help?
So this goes into, we have a short amount of time, but I'll try to explain this very quickly. So testing is not like the Bat computer, right? From the old Batman show with Adam West. You don't ask the computer a question. It doesn't go like ding and spit out a card saying yes or no.
Right.
Every test has its operating characteristics, and we look at this on 4 parameters to begin with, which are sensitivity, specificity, positive predictive value, and negative predictive value. And tests don't necessarily behave the way we want. So let's take a rapid test that we know of, which is the influenza rapid test, which is a similar kind of test to some of these card pregnancy type tests that are being used for rapid testing. So those tests, we know a negative result is almost completely meaningless, while a positive result is very suggestive of a positive test.
Mm-hmm.
So there you see a test where a negative result means nothing and a positive test is suggestive. So we come now to the rapid tests for COVID. They have similar operating characteristics in that a negative test is extremely unhelpful, but a positive test is very, very helpful. And there's rapid testing by these types of antigen tests, which work like pregnancy tests. And we have positive tests that work like rapid PCRs, such as the ID Now, which has made it big in the news. So ID Now is really good for symptomatic people within the first 7 days of symptoms. Asymptomatic people, not as good. Outside of that 7-day window, not as good. But some people are saying that, well, this is what we really want to know anyways, because the sensitivity and specificity of that test is tuned to a zone where people might be infectious, as opposed to the PCRs that we're doing, which are not tuned to infectivity. PCRs that we do in general are tuned to presence of viral target or not. And then that result has to be matched to the clinical syndrome. So there's an advantage and a disadvantage where you may be able to more accurately pick up people who are in an infectious period, but you may miss people who are pre-symptomatic, and you may miss people who are mildly infectious.
Fascinating. We have only the last couple of minutes. I don't know to what degree you'll be able to answer all of these questions. Which is your personal preference between the different vaccine companies is a question that was put forward.
I don't have a preference. I could tell you from before this all started, my preference was to have the protein subunit vaccine, which is one that's coming up. I think it's a GSK associated vaccine. It's going to be coming out shortly. I think they're in the midst of doing their phase 3 trial, where it's basically using a much more classic type of vaccine. Basically, I'm ultra conservative and a bit of a chicken, so I was hoping to go with something that I knew. So it's similar to I guess the closest thing would be something like the current shingles vaccine, which uses a protein subunit directly. It doesn't require your mRNA to be translated and into in the body. It gives a protein with an adjuvant. So some people don't like adjuvants, which are basically chemicals that are used to cause an inflammatory response to get a bigger bang for your buck on the protein. But they're generally ultra safe. The question is, how much efficacy are we going to get out of those? The studies are yet to be released. So I had a choice of getting a vaccine or not of getting Pfizer or Moderna.
Right. Right.
So I just took whatever that was offered.
And the last question for this evening, I'm sorry we weren't able to come to everybody who put forward a question. Do you believe that children under the age of 10 should receive the vaccine? And if so, when do you believe the timetable will arrive for them to receive it?
So currently, there is no recommendation for children or teenagers under the age of 16 and 18, depending on Pfizer, Moderna. They haven't been studied. I think it's Pfizer just announced that the enrollment in their next phase of adolescent studies has been completed. So they have enough to start their study on the adolescent group, and the next group will be children. And until that is done, I would not recommend anything to anyone. And remembering that children generally escape the worst part of this, 1 out of 10,000 to 1,000,000.
Right.
It's like very rare to have a severe case. Unfortunately, we know of some people who have had rare cases, but ultimately it's very rare.
Right. I want to thank you so much for taking the time this evening to speak to our community. I know that you have been working extremely hard, constantly, consistently over these last 10 months. And just the thought of how we began when you said that you took 1 week off simply for your own mental well-being. I can only imagine the stress and the pressures that you must be under, and the constancy that you have been dealing with so many life and death situations over this period of time. As a proud Beth Tikva member, I take my hat off to you, and I am in awe of you. And so many people here have mentioned over social media or this evening just their sense of gratitude to you, to all doctors in the hospitals, to all of the frontline workers, the nurses, the staff, the support teams, and everybody. We are so appreciative for what you do, for the research that you do, for how you've been able to be available to us and the broader members of the community, and for answering all of these questions this evening. I hope this has proven valuable and positive to everybody who has been watching this evening. It's clear that we will not leave this as long as 5 months again until I bring Dr. Marty Teltscher back. He'll have to agree if he's available. But I'd like to, on behalf of everybody at Beth Tikva Synagogue, and indeed all of those who have tuned in, thank you and just express our gratitude to you. Yesha koach to you, Marty. You, Rebecca, the whole family should be well. And please God, we will be behind this horrible plague very, very soon.
Thanks a lot.
All the best. Good night, everybody. Stay safe. And we will continue with programming this week and next with everything that we are putting out at the Synagogue with No Walls. While our institution and building may physically be closed, please know that Beth Tikva is here for you. We will continue to be here for all members in the West Island community in any which way we can. And there is a plethora of programming for you to continue. Stay tuned, have a good evening, and be well. Thank you.